My name is Ed Loftus. I'm a physician at Mayo Clinic, and I'm chair of the Inflammatory Bowel Disease Interest Group here in the Division of Gastroenterology and Hepatology. And I wanted to talk to you today about ulcerative colitis. The medications we use to treat ulcerative colitis aren't really directed against the root cause of the condition. They're directed against decreasing inflammation in the lining of the bowel in a somewhat nonspecific way. And we use a variety of medications. There are the sulfasalazine and 5-aminosalicylate class of medications, and these are really the mainstay of treatment in ulcerative colitis. These medications are widely prescribed for this condition and can often get a patient back into a full clinical remission, meaning a resolution of their symptoms. When these medications aren't effective, we will sometimes prescribe corticosteroids, also known as steroids for short. These aren't the steroids that you hear about athletes taking. These are steroids that reduce inflammation. Prednisone is a good example of those. These work well in the short term, but over time can result in side effects. When prednisone is not sufficient to control the symptoms, we'll move on to other classes of medications. One of those is azathioprine, or a cousin of azathioprine called 6-mercaptopurine, or another cousin called methotrexate. Now, methotrexate we don't use so much in ulcerative colitis, but it has been used by some. These medications modulate the immune system. They suppress the immune system slightly and can result in reduced inflammation. They're a little bit more complicated to use than the 5-aminosalicylate class of medications, and often require blood count monitoring and similar types of more closely followed monitoring. When this class of medication is not effective, then we will often move to anti-TNF therapy or biologic therapy. And the most commonly used agent for ulcerative colitis in this class is Infliximab, also known as Remicade. And this has been shown in a number of studies to be effective for some patients with more severe forms of ulcerative colitis. When medical therapy is not effective at controlling symptoms, or if a patient develops precancerous changes in the colon, then we'll sometimes recommend surgery. Surgery in ulcerative colitis usually involves removing the colon and the rectum, and nowadays this can be done by some surgeons, including some here at Mayo, in a laproscopic or minimally invasive fashion, and this has been shown to reduce the postoperative recovery from surgery, so that some people are getting out of the hospital only 4 or 5 days after their colectomy, and we're seeing pretty good results with that. They are now doing a procedure called incisionless proctocolectomy, where a person can have the colectomy with basically no open incision, just a few incisions for the laparoscopic ports. Of course, surgery it's a big step, but for some patients, if medications are failing, this can result in a significant improvement in their quality of life. And we found that over a 30-year period, that approximately 25% of ulcerative colitis patients will go on to require surgery for their condition. But most patients do not require colectomy. Life expectancy of patients with ulcerative colitis is actually longer than that of people in the general population. And the reason for that is there's a curious relationship between cigarette smoking and ulcerative colitis. And it turns out that most people with ulcerative colitis either never smoked or quit smoking. And it's unusual to see people with true ulcerative colitis who are active cigarette smokers. So there's something in cigarette smoke that seems to suppress bowel inflammation, at least in the case of ulcerative colitis. Now, that doesn't mean we go out and recommend to people that they take up cigarette smoking, but this might explain why the life expectancy of people with ulcerative colitis is actually a little bit longer than that in the general population. In terms of medications, we talked about the sort of standard medications but there are a number of clinical trials, investigational trials of newer agents that we're always involved in. And many of these novel drugs are monoclonal antibodies that block various aspects of the mucosal inflammatory reaction and thereby reduce inflammation and reduce symptoms. So at any given time we have 3 or 4 of these trials ongoing, and many patients who come here find that they are candidates for some of these investigational studies. In many ways it's difficult to categorize patients with ulcerative colitis with respect to the severity, and many patients ask us, what should I look forward to in the future with my colitis? And what we found over the years that the natural history of ulcerative colitis is quite fluctuating. And so a person may have a bad 1 to 2 years, but then they'll often go into a prolonged clinical remission and do well for several years. It's fairly unusual to see somebody develop ulcerative colitis and go into a prolonged remission for forever. And so this type of a disease, this chronic illness, is characterized by flares and periods of remission. Oftentimes when people come to our clinic, they'll come in on a Monday, and over a rapid period of time, usually 2 to 3 to 4 days, we can complete a battery of tests and see them back the same week with a global overview of what we think is going on with their inflammatory bowel disease right then and there, and we can often get them in to see the necessary consultants in other specialties if necessary.